At this year's ASH meeting, we'll be presenting data on a novel molecule called HM43239. This is a multi-kinase inhibitor that blocks multiple pathways, including FLT3, ITD, TKD, SYK, and also has activity on some other pathways like JAK and potentially AXL. So this is results that we'll be showing from a phase 1 study. The study is actually ongoing both in the US and in Korea in about 10 centers. And the study allows both relapsed refractory FLT3 mutated and FLT3 wild type. What we're seeing is that the drug is very well tolerated. In fact, that's probably the key highlight we can make at this time, is we actually have not seen any significant cardiac issues, QTc prolongation, GI problems, LFT abnormalities. So all in all, quite a well-tolerated drug, which is going to be important because eventually, like all drugs in AML, this will have to go into some form of combo, and having a good single-agent safety profile makes that quite feasible to be done in the future. And we are actually seeing activity. So we're still in a dose escalation, and at the third dose level of 80 milligrams and at the fourth dose level of 120, we've actually seen responses. In fact, a total of 6 responses have been noted, including 5 CR/CRIs and 1 PR, and the overall response rate at the 80-120 milligram dose is about 35-40%, including in FLT3 mutated patients who have received prior FLT3 TKI, which was very impressive because historically in people who have received prior midostaurin or gilteritinib even, it's very hard to get a response, and we've actually had a few of those patients and seen CR/CRIs. The CR/CRIs have been very durable, with most of those being maintained through transplant or long term, and now we're continuing to escalate. We're at the 200 milligram dose, and we should be finalizing recommended phase 2 dose soon. The study is actually now going to be expanded to an additional 10-15 centers in the US and other regions, and we're going to focus on patients with FLT3 mutated AML who had prior TKI. Now, one very interesting finding was we did actually have 2 of the 6 responders who did not have a FLT3 mutation. One of them was a TP53 mutated relapsed AML in South Korea who got this drug, achieved a complete remission, and maintained it for 14 months. So now it's an N1, but that's not something we normally see with other agents, single agents in TP53 relapse settings. So there may be something beyond just using this agent in FLT3 mutated. Early days again, but we are going to look at both high-risk TP53 adverse cyto relapse patients as well as the FLT3 mutated in the expansion cohort. So look out for that data hopefully next year. Thank you.